like to invite Dr. Vinod Kumar sir to the dais. He will be speaking on the on ultra-wide field OCT and OCT in peripheral retinal disorders. Sir is currently affiliated to Dr. RP Center and working as an additional professor in retina and uvea surfaces. Sir also has a keen interest in imaging modalities, so we are looking forward to his talk. Thank you.
Thank you, Mosmi. At the outset, I would like to thank Saurabh for his wonderful talk. So I'll be talking about a little less talked about topic called ultra-wide field OCT. Now, OCT has gone its undergone its evolution. If you remember, we had time domain OCT sometime back in 2000s, and we could see grossly the layers of I'll not say layers, but grossly we could see the retina, and with the onset of spectral domain, we could see the sublayers and the layers of the retina. I think even spectral domain OCT has undergone evolution in the sense that the scan speeds and the resolution have improved, thereby spectral domain still remains the standard and is the most commonly used OCT. Swept source has been introduced and has advantages over spectral domain in terms of higher depth of penetration. But till date, our evaluation of retina in terms of OCT has been restricted to posterior pole or maybe little beyond it. And we know that in today's scenario, OCT is virtually indispensable not only in retina practice but also other forms of ophthalmology. But something which has not been captured very widely using OCT has been the peripheral retinal degenerations. Our knowledge about peripheral retinal degenerations has been limited to the histological studies which have been available in the literature, and somehow we never delved into imaging the peripheral retinal degeneration by using OCT, partly because of our you can say inability to capture these using the currently available commercially available OCT devices. But I think sometime maybe a year or 2 years back, we had this particular instrument called Silverstone Optos. I would like to mention that I have no financial interest. So Optos, we know that it captures up to 200 degrees of retina in a single click, and it can capture up to the aura if we take the steered images. But till recently, we did not have the ability to do OCT with this particular machine. But with the onset of Silverstone, we had this swept source OCT, which was incorporated into Optos. And with the help of that, we can capture the OCT of peripheral retinal structures. Now, what it does is it gives around 1,000 A scans per second. That is a fairly high number of A scans to give us high resolution images of the peripheral lesions. So I'll not go into various other technicalities, but I'll just discuss our study which we did, which was a cross-sectional study. We took around 100 eyes of around 76 patients, and we imaged around more than 100 lesions in these particular eyes using this particular instrument. So this was a thesis topic we had undertaken, which was done after written informed consent and ethics approval. So all those patients who were identified to have peripheral retinal lesions using indirect ophthalmoscopy and who were cooperative and who could focus on the machine well, that means they had a good vision, were included in the study, and the patients which did not meet these criteria were excluded. So these are the various list of you can say peripheral retinal degeneration or lesions which we encountered in the clinical practice, and then we imaged them using ultra wide field OCT. So as we know, lattice degeneration is one of the most common lesion. So one of the beautiful aspects of Optos is that you can capture these images beautifully, and somehow always our knowledge has been restricted to the indirect ophthalmoscopy images using a camera, but with the help of Optos now we can image these. So when we analyzed our imaging, OCT imaging of lattice degeneration, our findings were almost you can say in line with the histological studies. So I'll share certain findings. So this is a lattice, OCT of a lattice. Now you might be wondering, how did we decide which scans we did take? So what we did is we took a raster through the area of interest, and then we analyzed all the raster images, and the images which showed the maximum findings were chosen for the analysis. So this is one such lattice. If you can see in the periphery of the retina, once you take the OCT scan, you will not find a horizontal scan like we typically get at a posterior pole. So you will see most of these scans are slanting because the eye wall becomes slanting and the retina becomes slanting anterior to the equator. So what happens is, when we image the lattice, you can see there is irregular thinning of the retina across its whole length. You can see there are some cystoid changes inside the lattice retina, and what is very well known is we see a traction at the edges of the hole. Now sometimes we can see holes in the lattice, sometimes we do not see holes in the lattice clinically. But what we found in our study, that the number of lattices where we could find these full thickness holes were more than the clinical number. So that is again very significant, especially in predisposed patients. If you have a hole, you would like to treat these patients prophylactically. So as I mentioned, various lesions can be seen, which are usually may not be visible clinical. So again, this is a patient, you can say there is a lattice degeneration. Clinically there is no hole and there is no subretinal fluid. But once you go on to do the OCT, you can see that there is traction along the edges. That explains why we always get tears at the edges of the lattice. You can see there are pockets of, you can say, small degeneration or subretinal fluid beneath the lattice, and at times you will be able to capture a hole which you cannot see clinically. Similarly, in snail track degeneration, which is very similar to, you can say, lattice degeneration, but we did categorize them as separate category in this study. You can see there is irregular thinning. Sometimes we could see the hyperreflectivity of the inner retinal layers, and again traction along the edges. So this is a patient. You can see there is a snail track degeneration with multiple holes visible. The large holes, you can see there is subretinal fluid again, which is not visible clinically. There is traction along the edges. There is degeneration of the inner retina, and you can see there are multiple holes when we scan the lattice along its length, which signifies, along with SRF, that this particular lesion needs imminent attention. This is a patient with white without pressure area, again very commonly seen, but when we did OCT through this lesion, we did not find. Most of these lesions were found to be normal on OCT. So if you notice one thing, what we see different from the posterior pole OCT is the retina is very, very thinned out. So that is what actually happens as we go into the periphery, the retina gets thinned out. So this is a patient, you can see there is a retinoschisis here clinically, and you can confirm with that with the help of OCT. And in these patients, sometimes you can have RD, which is not very easily deciphered on clinical examination. So this can be very easily picked up with the help of ultra wide field OCT. Now look at this particular lesion. If it looks like as if there is thinning of the retina, or maybe there is some clinically there is some you can say retinoschisis as well. But when we image this particular lesion, you can see there is no schisis. All you can see is irregular thickening of the retina, which is probably leading to this particular appearance. So clinically speaking, you would be inclined to treat this lesion, but once you see on OCT, you are reassured that this particular lesion does not need any treatment. Again, paving stone degeneration very commonly found, but when we image these particular patients, you can see, as is expected, the RP, this particular layer, which is absent from this area, and that is why you can see the underlying sclera and the large choroidal vessels. A particular hole you can see over here, very nicely seen. There is some amount of subretinal fluid, and that can be seen that there is a traction on this hole, along with subretinal fluid. Now, classical teaching is that when there is a degenerative hole, you do not need to actually treat it. But once you see the traction on the edges of this hole, this is the hole which needs to be treated. Otherwise, this fluid can extend and lead to a full-fledged RD. We had certain lesions which clinically we could not categorize into anything. We labeled them as doubtful, pigmented or non-pigmented lesions. When we analyzed them, we found that one lesion out of these had a subclinical hole with SRF along with traction. 2 lesions showed splitting of the retinal layers and various other findings. So I'll show you the representative ones. If you can see here, very non-specific lesion, you cannot categorize into anything. There is some pigmentation here. You do the OCT, you can see there is a very well localized traction over here along with a full thickness hole. Again, this lesion, in this scenario, it would be better to treat. Again, a particular lesion, you can see a pigmented sort of lesion anterior to the aura. Normally, you would just label it as a pigmented lesion and probably not treat. But you see on OCT, there is a retinal flap, a full thickness hole. There is no fluid as of now. But again, in your clinical practice, you would like to treat this one. My last 1 or 2 slides. This is a very interesting patient. This, you can say, microcystoid kind of degeneration which was there. Once we did the OCT, we found that there was schisis in the area of ora serrata, and nothing was done to this particular patient. A patient with CHRP where there is atrophy of the where a depigmented lacunae, you can see the RP has become atrophic. A meridional fold, again, we do not pay much attention to it, but you can see on wide field imaging there is probably a hole. There is a paving stone degeneration here. You do a OCT, you can see there is a hole along with subretinal fluid. So this is a meridional fold which is going to cause a RD and needs to be treated. Sometimes patients are referred, these patients are referred as lattice degeneration. Ora can be very easily confused with lattice degeneration, but this is a patient with ora which shows a microcystoid degeneration. There are certain limitations, of course, cost being the major thing, but as we go into the periphery, the image resolution goes down, and it's very difficult to achieve consistent central fixation and proper alignment in these cases, especially when you're using it for periphery. To conclude, it's a useful technology, especially when you are in the uncharted territories. There is a learning curve to obtaining scans in the periphery and also the interpretation, but it can aid in the decision making, though cost is a big hindrance. Thank you very much.
Congratulations, sir, for this study. So I think the house has some questions. Any questions, please?
Yeah, these are mostly steered images. So what we do is on Optos, first we image the lesion, and once the image is, once the lesion is imaged, then you place your raster scan on that particular area. So that is the challenge that you have. The patient has to look in that particular direction, and it's not easy to hold the patient's. Yeah, it's not easy for the patient also to hold the gaze in one direction for long, and the scans do take a fair bit of time as compared to the normal OCT scans of the posterior pole. Layers are never going to be clear because sometimes the layers are so thin it's very difficult to make out on which side is the retina. But I think as in the beginning it was difficult, as we saw more and more images we became more experienced. Now I think it's become easier. But the layers, histologically also you can't appreciate the retinal layers in that far in the periphery. Yeah.
But if you go with RGB, you will clearly demarcate the retinal traces.
Yes. What happens is most of these degenerative schisis, they happen in the periphery. They are elderly patients. Some amount of cataract is also there. When I am suspecting schisis, the best modality to do is IR images. So RGB or RG. So what you do is you take them to IR spectrum, and then you will see your schisis very beautiful.
Sir, I have a question for you. Sir, according to you, after doing this study, what was the extra advantage you felt, something which is going to help?
See, it's not every patient is going to benefit. That is what I wanted to highlight. But there is certain subset of patients where you will find extra findings.
Especially the vitreoretinal interface changes
Changes
which may
which you can see. And certain, there are lesions which clinically you would be inclined to treat. You image them and you will see there's nothing there, like I showed you that cobweb kind of thing, and you can leave them safely. Otherwise, clinically you will be little confused, you will be apprehensive, you will keep on calling the patient. You see on OCT everything is alright, you can sleep peacefully. On the other hand, there are some lesions which look benign, but you do a OCT, there is a traction, there is a fluid, so those are the lesions you need to treat. So it's not going to benefit all the patients, but 10 to 15% of your eyes, your decision is going to change.
Any more questions?
For the first speaker, how will the differentiate between Drusen and
So, yeah, sure.
So pseudodrusen are usually above the RP, while normal drusen, the conventional drusen, are below the RP. Again, pseudodrusen are of two types, the nodular ones and the reticular ones. The nodular ones are very easily identifiable. You can do, you can say blue reflectance or green reflectance image, and you can see the nodular image. You do the OCT, they are, you can say, triangular kind of shape above the RP. But the ribbon types, pseudodrusens are relatively difficult to identify. They are kind of web kind of thing, and even on OCT they are little difficult to, you can say, assess. But with experience, I think nodular are very easy to identify. Once you start identifying nodular, then you can shift on to ribbon types.